Hello, friends. Welcome to Unacademy. Let's crack NEET PG. I'm Dr. Shonali Chandra, and in today's session, we will be taking up MCQs from the topic that is contraception. And I will be taking up more MCQs on contraception tomorrow as well. I have highlighted my reference code here, friends. That is my name, that is SHONALI. So if you subscribe to the Unacademy platform using this code, then you can avail a 10% discount on your subscription package. Unacademy is India's largest learning platform. If you take a plus subscription, you'll get daily live classes where you can chat with your educator, interact, ask your doubts and queries, and get them solved there and then. So it's like a live classroom experience. The courses are structured keeping in line with the latest NEET PG syllabus. There are also live tests and quizzes which will evaluate your performance as you go along. And most importantly, one subscription gives you unlimited access. So you can watch all of the live sessions from all the faculties who are active on the platform. And even if you miss out on the live sessions, you can always go back and watch the recorded versions from the comfort of your own devices. Top educators are associated with the platform. All 19 subjects which we need to prepare for our postgrad entrance exams, they are covered. And every now and then, comprehensive batch courses and also short duration crash courses, they keep getting launched. So you can check out the ongoing courses in the platform as well. And as far as the subscription packages go, you can take one depending upon your need and requirements. So if you're targeting the upcoming exams, you can take a shorter duration subscription to help you prepare with a crash course. Or if you are targeting the next exam, then you can take the longer 12-month subscription. It will give you ample time to go through all of the sessions and will also leave you enough time in the end to revise. And it turns out to be more economical also in the longer run. And if you're in your third year or final year MBBS and want a slower pace of preparation, you can take the 24-month subscription. It turns out to be far more economical in the longer run. And if you subscribe using my code, that is SHONALI, then you can avail a 10% discount on your subscription package as well. So, informing you about the upcoming free live classes which are taking place on the Unacademy platform. Tonight, 20th of October, 8 p.m. I'll be taking up MCQs on partogram and clinical management of labor, which will further continue on 22nd of October, 8 p.m. again, same time. Again, talking about MCQs on clinical management of labor. So you can join me there as well on these free live classes. You can check out the plus courses which I've completed on the Unacademy platform. There's a capsule course on reproductive gynecology, on high risk pregnancy, and also on gynecological oncology, so dealing with the cancers, important cancers. So you can check out these plus courses also on the Unacademy platform. So coming back to the session at hand today. So, good evening, Suvarna. Good evening, Syed. You're in Ethiopia. It's midday. In India, it's evening. It's evening 4 p.m. in India. So, good evening, Syed Abdo. And good evening, Suvarna. Hello. Welcome for joining in for the MCQ session on contraception. So, without wasting any further time, let's just get started. And let's have a look at the first question of the day. So, there's a 28-year-old woman who requests a reversible contraception. She is healthy and without any medical problems, and also has a normal pelvic examination. Now, while reviewing her options, she asks which method is most reliable. So, which of the following methods has the lowest pregnancy rate per 100 women using the method perfectly for 1 year? Is it copper containing intrauterine devices? Is it the long acting progesterone contraceptives? Is it the combined hormonal occipitals or the diaphragm? Which method has the lowest pregnancy rate when talking about per 100 woman year of use, and that too using the method very perfectly and consistently? So, yes, anybody has an idea about that question here. Copper containing IUDs, long acting progesterone contraceptives like the injectable progesterone contraceptives, like the implants that they're talking about, or combined hormonal oral contraceptive pills and diaphragm. Now, out of all of these, Saeed Abdul rightly saying it is the long acting progesterone contraceptives which have the lowest pregnancy rate when clubbed together. Good evening, Shaitaj and Satya and Satish, rightly saying that long acting progesterone contraceptives have the least least failure rate. Now, well, all of these currently used contraceptive methods, like especially the hormonal contraceptive methods, they all provide a very good effective, efficacy and effectiveness, allowing for very low pregnancy rates, be it the copper-containing IUDs or the progesterone methods or the combined hormonal pills. When you talk about the barrier methods of contraception, like the condoms or like the diaphragms, they have got a lesser efficacy. They have got a higher pregnancy rate, and even in the barrier methods, condoms are very good. They provide good efficacy as well. So let me just quote here from the WHO medical eligibility criteria for contraception, which the booklet they hand out. These are given by the WHO, and the latest booklet that I found was from 2015 here. So what are the failure rates with different contraceptives? So we'll talk about the perfect use. So condoms, be it male or females, they provide very good contraceptive efficacy, but not as good as the hormonal method. So the failure rate is somewhere between 2 to 5%. All right. If you talk about the diaphragm has got a higher failure rate as compared to the condom methods. If you talk about the combined pills and the progesterone only pills, they have equal failure rates, so 0.3, so in that range. So if you talk about all these methods here, like the combined pill or the progesterone only pill, the patch or the NuvaRing, these are also the estrogen plus progesterone methods. If you talk about the Depo-Provera, they also have equivalent failure rates. But if you talk about the intrauterine devices here, now Copper-T has got a failure rate of about 0.6% with perfect use, and Mirena has got a failure rate of about 0.2. And if you club the Implanon, if you look at the implants here, Implanon is the progesterone containing implant that affords the least failure rate here of 0.05%, right? So all of these hormonal methods, they are equivalent as far as the failure rates are concerned. But yes, these implants, these are the progesterone implants we have, right? These implants have the least failure rate. These are the long-acting contraceptive methods which are in use. Mirena is also progesterone containing long-acting reversible contraception. It also offers a failure rate which is less than the other hormonal pill-based methods, right? So the answer to this question is yes, progesterone acting long-acting contraceptives, they have the least failure rate if you talk about all of these methods as given in this chart here. Now let's have a look at the next question. A 21-year-old woman and her husband want to use natural family planning methods. Her menstrual cycle length varies between 26 to 32 days, with day 1 being the day that menses start, the time of maximum fertility during which she should be abstaining from intercourse is taken to be between day 1 to day 14, between day 8 to day 21, between day 14 to day 21, or between day 10 to day 18. Which is the right answer here? So a woman whose menstrual cycle length varies somewhere between 26 to 32 days, more or less regular cycles, but the cycle length varies. If day 1 is being considered as the day that when the menses begin, the bleeding starts, the time of maximum fertility, very good. Saeed Abdo is very quick at answering this question. Richa, good evening to you. Nana, good evening to you as well. Satish has also joined in. So for this particular woman, the time of maximum fertility is between day 8 to day 21. Day 8 to day 21. So if you talk about this fertility awareness based methods, we know that the time of maximum fertility is around the time of ovulation. Now the time of ovulation is considered to be day 14 in a woman who has regular menstrual cycles of 28 days. But if a cycle length varies, then of course the ovulation day can be here and there. right? So what is important to note here is that the sperm is also fertilizable in the female genital tract for a period of up to 3 days. So that also has to be accounted for, right? So that is why a longer duration of this fertility period is there. And in general, it is considered that a woman who is having cycle length varying between 26 to 32 days, but more or less regular cycles, she can use these natural family planning methods based upon the standard days method. And according to that method as given by WHO, the period of maximum fertility ranges somewhere between day 8 to day 19 of the cycles, right? So on an average, these are the days during which maximum fertility is there, and that is the time when one should abstain from intercourse. So let us just go through this natural method, these fertility awareness based methods. It's the rhythm method or the calendar method or the standard days method. So if a woman has regular cycles, the unsafe period is the period when the fertility chances are maximum. That's somewhere between day 8 through day 19. If she has irregular cycles, then the fertile period can be calculated as the shortest cycle length. Like for example, in this previous question, it would be 26 minus 18 to the longest cycle, that would make it 32 minus 11. And that is how we've got the answer of day 8 to day 21 of the cycle. Right now, to ease the use of this method in lay people, in couples who are wanting to use this method, there's also these cycle beads. There are also these cycle beads which are available, and you can see here that the days, that is white beads here, these white beads here, which are spanning from a period of day 8 to day 19. These are the white beads where pregnancy is most likely. So a woman can use these cycle beads. So red bead is where it is considered as the day 1 of the cycle. Then she starts changing the beads. She starts changing the beads every fresh day. So day 1, day 2, day 3. So when she reaches day 8 and through day 19, it is considered as the chance of highest fertility. During the brown bead days, she should be avoiding intercourse, right? So this is the concept of the standard day method. And yes, of course, the calculation of these standard days methods have given to you how they are calculated. In general, yes, day 8 through day 19 of the cycle is considered as the time when there is highest fertility. So that is considered as the unsafe period. Now, let's have a look at the next question. Now, the diaphragm use provides a mechanical barrier to the ascent of sperms from the vagina. So diaphragm is considered as a barrier method of contraception. It provides a mechanical barrier to the ascent of sperms from the vagina. So the woman has to introduce this diaphragm into her vagina before sexual activity. Now, they are often used together with spermicidal jellies to increase the effectiveness of the diaphragm. These spermicidal jellies, they destroy the spermatozoa. How? Primarily by activating the acrosomal enzymes of the sperm head, or altering the vaginal pH, or altering the vaginal enzymes, or they are spermicidal by disrupting the sperm cellular membrane. So very good, Saeed Abdul Richa rightly saying, Satish also rightly saying that spermicidal jellies, they are active against the spermatozoa. They are spermicidal, sperm toxic by disrupting the sperm cellular membrane. And it would be a good thing to remember here that isolated use of spermicidal jellies is going to give a higher failure rate. The use is often combined with the use of diaphragm. So seeing here, what is a diaphragm and what's a cervical cup? Let's just quickly recapitulate here. So these diaphragms are, silicone based, products which are designed in a manner that they can be fitted inside the vagina. So you have a diaphragm here. This is the diaphragm. It's more broader here. Okay. And if you see the cervical cup here, this is it is smaller and it fits more snugly onto the cervix. But the principle of their uses is the same. They have to be introduced inside the vagina digitally by the woman herself. Now, the diaphragms and cervical cups, they give the control of contraception to the woman, of course. Yes, that's one advantage there. And the other advantage here is that it does prevent somewhat, against sexually transmitted infections. Not completely, yes, not completely, but some protection is, achieved against the chlamydia and gonorrhea, but they will not provide any protection against HIV. Please remember that, because the vagina here is still exposed to the semen, right? So that's why protection against HIV is not afforded by the use of diaphragm or cervical cups. Please remember that. And the other reason why women do not find this method often too good to use, and they're not really choosing this method most of the times, because it has to be, it interferes with the act of coitus in a manner that it has to be inserted just prior to intercourse, and not longer than 6 hours prior to intercourse, and then after that it has to be even left in place for at least 6 hours after the intercourse also. And at a single stretch of time, the woman cannot use this diaphragm for more than 24 hours, right? So that is why this is a method which is slightly, women find it slightly cumbersome to use and do not prefer to use it. And the effectiveness of the method definitely increases with the use of spermicidal jelly. So these spermicidal jellies are put here inside the cervical cup or inside the diaphragm, and then they are introduced into the vagina. So you can figure out the various side effects that this method is going to result in. It can lead to vaginal irritation here. It can lead to the irritation of the bladder in front also. It can predispose to urinary tract infections. If left for long durations, if due care and hygiene is not maintained while using the method, it can lead to cervical abrasion and cervical erosion also. And one limiting factor which exists for the use of diaphragm and cervical cap there is that it cannot be used if there is any degree of prolapse. Otherwise, it is going to be ill-fitting. It will not fit properly, and it might get expelled. So it cannot be used with conditions like prolapse of the genital structures. So keep these important points about the use of a diaphragm in mind as well. Sometimes women are wanting to know about, and in fact, it is good that a woman, when wants counseling for contraception, she should be counseled about all the available methods, about the risks and benefits and ways, about all the contraceptive methods, and then she has to make a choice for herself. That is how contraceptive counseling is done. Now, talking about vaginal spermicides. So these vaginal spermicides which are available in the market these days, they mainly contain non-oxynol 9. It is, this compound is a non-ionic compound. It has a surface acting detergent action that immobilizes the sperm. So it acts against the cellular membrane of the sperm, and it causes the disruption of the cellular membrane of the sperm. That's how it ultimately is going to lead to the decreased sperm motility. And these spermicides, they are going to provide no protection against a sexually transmitted disease or HIV whatsoever. But yes, these vaginal spermicides, concerns were raised whether these spermicides could be toxic to an early embryo, or maybe it could be toxic to the pregnancy somehow if failure resulted. But those fears are set aside. These vaginal spermicides, they are not absorbed from the vagina, so they are not thought to interfere with a pregnancy if at all it occurs, or lead to any chromosomal abnormalities or any pregnancy complications if at all a failure of this method occurred. But one thing important to note here is that frequent use of these vaginal spermicides, it can predispose to a different set of vaginal infections altogether. And the spermicides, they are toxic to the lactobacilli, and these lactobacilli are considered as the good, healthy vaginal flora. So lactobacilli can also decrease with prolonged and continuous usage of these vaginal spermicides, right? Now, Berural cervical cap used causes cervical cancer. There's no concrete data regarding this. I mean, it's not considered that it does. Okay. The concern is definitely there, but no studies have found a definitive cause and effect relationship there. Now, let's have a look at the next question. There's a young woman and her partner who want to use condoms as a barrier method of contraception. The couple should be advised that the most common reason for failure of the method is condom breakage, inconsistent use, using without spermicides, or condom slippage. So they should be advised, the couple should be advised that what is the most common reason for failure of method. So couples who are using condoms as a method for contraception, they should definitely be insistent on using the method consistently and using the method properly, right? Because inconsistent using it sometimes and then not using it at other times, or there is a tendency of couples to wear the condom in between the act. So that should also be discouraged. The condom should be used consistently and properly. So inconsistent use of condoms is the most common reason of failure of the method. Condom can break, yes, they can definitely break. Friction during intercourse is cited as the reason for condom breakage. The risk of condom breakage is just on an average about 3%, and it is more common with the silicone based condoms rather than the latex based condoms. So condom breakage can occur, but it is not the most common reason for failure. And the condom breakage is particularly happens when Vaseline or petroleum jellies are used along with condoms during intercourse. So water based lubricants, they are good. Water based lubricants, they don't cause condom breakage, but if you use oil based lubricants like Vaseline or petroleum jellies, then that can predispose to condom breakage. Now when a couple uses condom, there is no additional use of using these spermicide jellies. So condom usage itself protects against sexually transmitted diseases and HIV also. It's a very good method to use. But yes, there is no need to additionally use spermicides along with condom. No extra advantage is gained by using these spermicides along with condoms, right? So keep that in mind. A couple who is wanting to use condoms as a method of contraception should be counseled regarding proper and consistent use of the method for good efficacy. Now, the barrier methods, let's just quickly revise the barrier methods. We have the male condoms. We also have the female condoms. Somehow the male condoms, they are more frequently used. I just talked about the failure rate of both of these methods also. And female condoms have a slightly higher failure rate, has been seen in studies as compared to the male condoms. And the female condoms, just like the diaphragm, they have to be introduced into the vagina before sexual intercourse. And the closed end is going to, this is the closed end, and the closed end is going to cover the cervix, and the open end is going to be here at the opening of the vagina there, right? So both male and female condoms, the biggest advantage offered by these condoms is that they protect against sexually transmitted diseases, HIV and pelvic inflammatory disease as well. And it is a very safe method to use because you do not have to worry about any hormonal side effects. These are barrier methods. They do not contain any hormones, so it can be used freely in couples who are apparently healthy, who have any medical indications where hormones cannot be used. So condoms can be used in those situations very freely. So no hormonal side effects are there. But importance is on to decrease the failure rate of condoms. The consistent and proper usage of condoms should be advocated. Now let's have a look at the next question. Now, there's a young nulliparous woman who presents to the OPD because the condom broke during intercourse. And this happened a day before. She's regular menstrual cycles otherwise, and her last period was 10 days ago. She does not wish to become pregnant. What should she be advised? There is no need to fear as she was not mid-cycle. She should be advised to await her next menses. She should be prescribed intravaginal misoprostol, or she should be prescribed levonorgestrel tablet. So a young woman presents to the OPD because a condom broke during intercourse, and this happened a day before. She's very worried. She does not wish to be pregnant. So, can she be offered something? Yes, very good, Saeed Abdo. She can be offered levonorgestrel vaginal tablets, right? There's no need to fear as she was mid cycle, is something that you will not tell her. She's still in that fertile period range. She can very well conceive. Even if she weren't mid cycle, she could have conceived. So, there's no need to fear. This is a completely wrong statement to make. If you wait for her menses to come, she might just already get pregnant. So waiting for menses is too long a time. She does not wish to get pregnant. So to prevent pregnancy from taking place, when we used contraceptions in such emergency situations, it is what we call as emergency contraception. You cannot prescribe her vaginal misoprostol. Misoprostol, this is a PG even analog, and this has no role in providing emergency contraception. This is an abortifacient. Misoprostol is a drug that induces abortion, not prevents pregnancy. So this is completely out of the question here. She needs to be given emergency contraception, for which we can prescribe her levonorgestrel tablets. So, talking about emergency contraception, what is emergency contraception? As the name suggests, it should be taken in situations of emergency, right? So, they can be used in situations like whenever there has been an unprotected intercourse somehow, or a woman was on some regular method of contraception, like she was taking regular pills and she's forgotten to take pills for a couple of days, or she was using condoms that slips or breaks, or if a rape happens, then also we do we do prescribe emergency contraception to these women, right? An important thing to remember here is that this is emergency and this is contraception, but this is not a regular method of contraception. So woman cannot be using this method again and again, right? So she cannot be doing this, that today episode happens and she uses the emergency contraception, then a couple of days later she does it again, and then she keeps doing that every month. So it's not a regular method of contraception. So to avoid pregnancy, a regular method of contraception is important. Emergency contraception is reserved for emergencies only and is not a regular method of contraception. Now, most commonly used method is the levonorgestrel pill that comes in the trade name I pill in our country here. So in our country, the prescription is not required. No prescription is required for this I pill. It can be bought over the counter, and that is the whole point of having an emergency contraception, right? So you don't have to knock at the doors of the hospital every time you need an I pill. So prescription is not required for this tablet I pill, that is levonorgestrel pill. How to take? It should be taken as soon as possible, preferably within 72 hours of the unprotected intercourse. So the sooner taken, the better. The highest efficacy will be seen that if you take it within 12 to 24 hours of the unprotected intercourse. But yes, preferably within 72 hours. If you take it beyond 72 hours, then the efficacy of this method is going to decrease, and then the chances of having failure will be there. The dose that is recommended is 1.5 milligrams single dose. So nowadays the tablet that is coming contains a single tablet of 1.5 milligram. It should be taken within 72 hours. Earlier, yes, 0.75 milligram tablets were there, and then one was supposed to take one tablet, and 12 hours later one was supposed to repeat the dosage again, right? So nowadays, yes, a single dose of 1.5 milligram tablet is available, and that should be used. Now, talking about this levonorgestrel containing pill, important thing to note here is that it can be used by any woman. Now, no medical complications have been reported by usage of this pill. It's a single time usage, right? It's a one time use, and the dose is also low, so it can be used by any women. No medical complications are reported, no metabolic side effects are there. And even if a woman uses this method and it doesn't work and she goes on to conceive, then she'd not be scared that I've taken a pill last month and now I've gotten pregnant. Could it result in any fetal abnormalities or malformation? So you should counsel the woman that even if this pill doesn't work and she goes on to conceive, it will not be associated with any fetal malformations or congenital defects. If this method were to fail, there is no particular increased risk of having an ectopic pregnancy also. But one thing that definitely needs to be counseled or to such a woman who comes requesting for emergency contraception is that it is not a substitute for regular contraception. So contraception counseling is a must in these cases. Now, there are various methods for emergency contraception. The one I described to you just now, it is what is most commonly used, that is the levonorgestrel eye pill. Yes, initially when the emergency contraception was introduced, combined pills were in use. Then there's a USPE method which has been described. So USPE, when initially introduced this method, there were 50 micrograms of ethinyl estradiol containing pills, right? So with those high dosage pills, he described that, two combined pills should be taken immediately, and 12 hours later, again, same two pills should be repeated. With the current low dosage pills which are in the market, which contains 20 to 30 micrograms of ethinyl estradiol, if a woman is using the USPE's method, she needs to take 4 of such tablets at a single time, and then 12 hours later repeat another 4 tablets. Now, taking such high dosages of estrogen progesterone containing combined pills often leads to immediate nausea and vomiting. So this method more or less is not very acceptable. Moreover, we have a very good method now here, free of side effects and with ease of administration, that is the levonorgestrel eye pill. So that's why it is mostly preferred. Now, what's the failure rate of this levonorgestrel eye pill? If taken within the first, as soon as possible, it should be taken preferably within 72 hours. And if taken within the first 12 to 24 hours, the failure rate is only about 0.1 to 0.2%. So that's a very less failure rate. Yes, 0.1 to 0.2% only. So it is very efficacious. And the another pill that is being marketed for emergency contraception is the ulipristal acetate. It comes under the trade name Ella, and a dose of 30 milligrams single dose, 30 milligrams single dose tablet can be used. The advantage of this tablet, ulipristal acetate, is that it can be taken within 5 days of the unprotected intercourse, and that's one significant advantage. But yes, ulipristal acetate is not available over the counter, so a prescription would be needed for this ulipristal acetate pill. IUCD, intrauterine copper containing device, right? Intrauterine copper containing devices like copper T, they can also be introduced as a method of emergency contraception. They are very, very effective method. And obviously, I would prefer, let's say, for example, there's a multiparous woman and she's had an unprotected intercourse and she comes requesting for emergency contraception. She can be counseled to get an IUCD fitted, because once it is fitted, she can, the method can continue as a consistent method of contraception as well. So IUCD can also be used there. Mifepristone is also studied, has also been studied for emergency contraception in all dosages, be it 100, be it 200 200 micrograms, or be it 50 micrograms or 10 micrograms. So mifepristone has also been studied in varying dosages, be it 200 milligrams or 100 milligrams or 50 milligrams or 10 milligrams. So the latest studies are that mifepristone in a dose of as low as 10 milligrams is also very, very effective for emergency contraception. The limiting factor is that such tablets are not available in the market most often. So that limits the usage of mifepristone in clinical scenarios. So we are mostly relying on levonorgestrel usage, right? Now, let's talk about in brief about this intrauterine copper containing devices for emergency contraception. You should remember that they are the most effective form of emergency contraception. So among all of these methods, overall, the most effective form of emergency contraception is IUCD. They are effective for up to 5 days after unprotected intercourse. Once placed inside, the copper that is present in the copper containing IUDs, that copper ions, they are toxic to the sperm, so they prevent fertilization. These copper ions, they also lead to an inflammatory reaction at the level of the endometrium, and they prevent implantation as well. And yes, it's a foreign device which is placed inside the uterus, so it's usually not preferred in women with an increased risk of sexually transmitted infections, right? So keeping these forms in keeping in mind these various emergency contraceptive methods which are available is important, so a woman can be counseled accordingly for the usage of these methods. Now let's have a look at the next question. This woman who wanted an emergency contraception, she's apprehensive about the fact that the method prescribed might lead to an abortion in case pregnancy occurs, and she's not willing for that. She's counseled all of the following except the method acts by preventing or delaying ovulation. It is not an abortifacient. She's counseled for contraceptive use. She can use this method on a regular basis. So she's counseled all of the following except. So this woman who came with emergency for the need of emergency contraception, you were wanting to prescribe her levonorgestrel. She raises the concern: what if the method fails? Will it lead to an abortion? And what do you counsel her? Yes, very good, Shataj and Said Abdo. Also, she can be counseled all of the following except option number D. Very good, Neo. So she can use this method on a regular basis. That's a false statement, right? So emergency contraception is not a regular method of contraception. The most important mechanism of action for emergency contraception, that is this levonorgestrel containing pill as well as ulipristal acetate, both of these methods as well as ulipristal acetate, both of these pills, they act by preventing or delaying ovulation. That's why they are so very effective. It's not an abortifacient. If the woman happens to conceive, it will not cause an abortion. So these fears should be allayed. It is not an abortifacient. Okay, so this is also a true statement. Option number A is also a true statement. Even if a woman takes a levonorgestrel pill or ulipristal pill for emergency contraception, if it works fine. If it doesn't work and she happens to conceive, it will not cause an abortion. And now is the time to counsel her for regular contraception use as well. So option number D is the false statement. She cannot use this method on a regular basis. She should not be using this method on a regular basis. Now let's have a look at the next question. There's a young 24-year-old woman who comes for contraception counseling. She's healthy and she has a normal pelvic examination. She wants to use oral contraceptive pills. Which of these is the main mechanism of action of combined OCPs? Inhibiting gonadotropins, inducing endometrial atrophy, preventing implantation, making the cervical mucus thick. Now, combined oral contraceptive pills, they contain ethinyl estradiol plus progesterone. Now, there are various kinds of progesterones which can be present in this combined oral contraceptive pills. They can be levonorgestrel containing oral contraceptive pills. They can be desogestrel containing low dose oral contraceptive pills. Whatever be, the mechanism of all these combined oral contraceptive pills is the same. They work by very good doctors Ebunisha, Saeed Abdo, Richa and Gemichu and Berulal Nena. Everybody answer correctly. They inhibit gonadotropins, right? So these are the progesterone part of the pill. The progesterone component of the pill is the main component, right? Main contraceptive component of the pill is this progesterone. Now, these high dosage of progesterone which a woman takes actually lead to inhibition of the gonadotropins, right? So follicular FSH is inhibited, LH hormone is inhibited, and that's how follicular growth and ovulation is prevented. So they prevent ovulation. That is how they mainly work. Apart from that, progesterone in addition also contributes to making the cervical mucus thick. That's also correct. They also induce progestational changes in the endometrium and make it unfavorable for implantation. All these are correct. But the main mechanism of action is the fact that ovulation is prevented by inhibiting gonadotropins, and that is the reason why these combined hormonal contraceptives, they are very, very effective because they are preventing ovulation. Now, let's have a look at the next question. So, over the years, the estrogen component of the combined oral contraceptive pills has been reduced. So, when the combined oral contraceptive pills were introduced in the very beginning, they began using 50 microgram containing ethinyl estradiol containing pills. Then we brought it down to 30 micrograms. Now we have 20 micrograms ethinyl estradiol containing low dose pills. And we have the ultra low dose pills also, which contains just 10 micrograms of ethinyl estradiol. So we've been consistently decreasing the estrogen component of the combined OC pills. Now this has minimized the estrogen related side effects, and we've been doing this, yes, particularly for this reason, that we want to decrease the estrogen related side effects, but this has led to an increased rate of failure in pregnancy, thromboembolic complications, insulin resistance, or breakthrough bleeding. Yes, so Saeed and Shahtaj rightly answering this low dose, very low dose estrogen containing pills, the ones that are 20 microgram and even lower than that 10 microgram. So the lower the dosage of estrogen in the combined pills, more is the breakthrough bleeding. More is the breakthrough bleeding. Now thromboembolic complications, they are estrogen related. They are estrogen related. So thromboembolic complications, they are much less with the current low dosage pills, right? 10 microgram, 20 microgram. With that, the risk of thromboembolic complications is very, very less. They were higher when 50 microgram ethinyl estradiol containing pills were in use. Failure in pregnancy, no, estrogen has not got anything to do with failure, and the estrogen dose is not contributing to contraceptive efficacy. The main contraceptive efficacy is coming because of the progesterone component of the pill. So failure in pregnancy is also not related to the estrogen dosages. Insulin resistance. Now insulin resistance can be triggered by the use of combined hormonal contraceptives, but not in all women, not in apparently healthy women, right? Only if there is a prior existent history of diabetes mellitus, only then. And that too, the risk is not significantly high. The risk is progesterone related. This risk of insulin resistance is progesterone related. So what has been the main side effect of decreasing estrogen dosage in the combined hormonal pills is breakthrough bleeding. Now why does that happen? Now when estrogen and progesterone pills, they are used together, combined methods, right? The overall effect of this combination, the overall effect of oral contraceptive pills is more progestational, right? Now progesterone, what it does, it causes thinning of the endometrium. Progesterone causes stabilization of the endometrium. So it causes thinning of the endometrium, which can lead to breakthrough bleeding, right? The reason why estrogen is anyways incorporated in the pill, right? So the main contraceptive efficacy is because of the progesterone component of the pill, but the estrogen component of the pill is actually kept there or added there to avoid this breakthrough bleeding, so that some proliferation or building up of the endometrium takes place. So the estrogen in the pill actually prevents from breakthrough bleeding. Okay, because a thin and progestilized endometrium has the tendency of bleeding in between. So this estrogen component actually prevents from breakthrough bleeding. Now the lesser the estrogen component, the more the risk of breakthrough bleeding, right? So keep this in mind also. It is the most common side effect which is reported by women who are initiated on combined oral contraceptive pills. It is one of the most common side effects that women complain of, and it's a nuisance complication. Nobody likes to bleed off and on every now and then, somewhere between the cycles. So this is the most common side effect which women report. So let's have a look at the next question. There's a young woman who was prescribed low-dose oral contraceptives for contraception. She returned after 1 month with complaint of episodes of spotting. So she's having breakthrough bleeding. She's concerned about the failure of the method. Okay, she's thinking that maybe she's not taking the pill correctly. She's having episodes of spotting in between. She's worried if this method is working for her or not working for her. So she's come back after a month with these complaints. So she's counseled all of the following, except she should continue the method. With consistent use, there is no increased risk of failure. She should switch over to another method, or this is most likely to resolve in a few months. She is counseled all of the following except. So, what is she not counseled? What is it that you're not going to tell her? She has been prescribed low dose oral contraceptive pills. It's been 1 month that she's been using it. She has complained of some episodes of spotting in between. She should be counseled that she can continue to use the method. She should continue to use the method true with consistent use. If she's been taking the pills regularly, not missing the pills, taking them at the same time each day, she's been using it consistently, there is no increased risk of failure. Like I just described to you, that the mechanism of action is mainly progesterone dependent. Breakthrough bleeding has got nothing to do with it. It's just that understand that this breakthrough bleeding is like the endometrium, which is adjusting to the new hormones or the pills, right? So with consistent use, there is no increased risk of failure. That's also a true statement. And women will continue to use it for another 2 to 3 months. And in most of the women, within the next 3 months, this condition should resolve on her own. So this is most likely to resolve in a few months. That's also true. There's no need to immediately switch over to another method, right? So there's no need to immediately switch over to another method. So that's the false statement here. So most of you answered this correctly. Yes, there's no need, urgent need to immediately switch over to another method. She can continue taking the method. She can continue taking the pills for another 2 to 3 months, and then she can be reassessed. If she continues to have the same problem, she can be put on same oral contraceptive pills but with a higher dosage of ethinyl estradiol. Maybe if she's using the 10 microgram containing pills, she can be switched over to the 20 microgram containing ethinyl estradiol pills, or cyclically in between she can be given estrogen therapy for 7 to 10 days in between the cycle. So there are other means of managing this breakthrough bleeding, but yes, there's no urgent immediate need to immediately switch over to another method, right? So breakthrough bleeding, a very common complication of usage of low dose oral contraceptive pills. You should always know, if a woman comes to you with these complaints, what should you be telling her? Now let's have a look at the next question. There's a 37-year-old obese woman. She wants to use oral contraceptive pills for contraception. She has a history of diabetes for the past 3 years, which is controlled on diet and metformin use. She has been a chronic smoker for the past 5 years. Her BP is 140/90 mmHg. General physical and pelvic examination is otherwise all normal. Her lipid profile shows mildly raised cholesterol levels. You advise her against the use of oral contraceptive pills, mainly because of the history of smoking, her age, the presence of diabetes in her, the raised cholesterol levels, or hypertension. What is the one main reason why you would not want to prescribe oral contraceptive pills in this woman? Yes, she is 37 years old. Yes, she is obese. Yes, she has a history of diabetes. BP is slightly on the higher side there, just there, 140/90. Mildly raised cholesterol levels, all reasons of concern. But the most important reason here is smoking. Smoking is the main reason why I will not prescribe this woman oral contraceptive pills. So age more than 35 is no longer considered a contraindication for initiating oral contraceptive pills. Even healthy women who are more than 35 years of age, who are not smoking by the way, they can use oral contraceptive pills. Diabetes by itself is also not an absolute contraindication. Yes, of course, if the diabetes is uncontrolled, if there is diabetic vasculopathy, if the diabetes is complicated, then one does not use oral contraceptive pills at all. Raised cholesterol concentration, yes, it is a cause of concern, but it is mainly the triglyceride levels, which when raised, they are a absolute contraindication for initiating oral contraceptive pills. And hypertension also by itself is not an absolute contraindication as long as it is well controlled. Yes, uncontrolled hypertension on the other hand, complicated hypertension on the other hand, is an absolute contraindication. So among all of these, smoking, a chronic smoker for the past 5 years, is an absolute contraindication. If you want to add to that even more, it has been said that smoking 15 cigarettes daily is considered an absolute contraindication of oral contraceptive pills. So I just want to summarize the absolute contraindications for combined oral contraceptive pills. These are considered as category 4 for the use of oral contraceptive pills. Never ever we prescribe them here. So age more than 35 and smoking concurrently is an absolute contraindication. A past history of already suffering from deep venous thrombosis or a history of inherited thrombophilias, uncontrolled hypertension, coronary artery disease, pre-existing coronary artery disease, or multiple risk factors for atherosclerosis in a woman, or history of stroke in the past history of stroke, or a complicated valvular heart disease, migraine, not by itself, but migraine with aura is an absolute contraindication, breast cancer is an absolute contraindication, right? So history of breast cancer in the woman, a woman who has been treated with breast cancer recently will not be prescribed combined oral contraceptives, right? And diabetic vasculopathy, uncontrolled diabetes, these are absolute contraindications for women for combined oral contraceptive use. So keep that in mind. In fact, the age more than 35 by itself is not considered, age more than 35, remember, by itself is not considered a contraindication, is not a contraindication as long as the woman is healthy. Yes, of course, the risk of stroke, in these women will particularly increase if she is also smoking, if she's also suffering from hypertension, right? There is no concern about the risk of myocardial infarction also in apparently healthy women, even if they are age more than 35, right? So the risk of MI also increases only in those women who have already multiple risk factors for heart disease, multiple risk factors for coronary artery disease. If present, then the risk of myocardial infarction or stroke is increased. So keep that in mind, that it's safe for a woman to use oral contraceptive pills even if she's more than age 35. But yes, she should not have other contraindications. She should not be smoking, she should not be hypertensive, right? She should not have a history of deep venous thrombosis, or she should not have inherited thrombophilia. So otherwise healthy women, they can use oral contraceptive pills. Now let's have a look at the next question. A young college going student is considering combined oral contraceptives for contraception. She has researched the internet and she is extremely frightened that the pill can lead to dangerous side effects. You assure her that the pill has many benefits but can rarely, mind you, increase the risk of benign breast diseases, ovarian cancer, endometrial cancer, or hepatic adenoma. So yes, the pill can have side effects, but most of these side effects are extremely rare, right? So you assure her that the pills has many other advantages as well. The advantages far outweigh the risks that are associated with OCP use, right? So OC pills can rarely increase the risk of, very good, Said, Deepesh and Shivani, hepatic adenoma. So OCPs are protective against the rest of the conditions. So OCPs are beneficial. They prevent the benign breast diseases. Continued use of oral contraceptive pills has been found to be protective against ovarian cancer, endometrial cancer, as well as colon cancer, There is a slight increased risk. There is a slight increased risk of adenocarcinoma of the cervix with OCP use, right? So, but then, yes, because of the many advantages that it has, a woman should not be denied combined oral contraceptives because they slightly increase the risk of adenocarcinoma of the cervix. Yes, that increased risk is seen, but again, there's a slight increased risk. Hepatic adenoma, the risk also increases slightly, but hepatic adenoma in itself is a rare condition, right? And the oral contraceptive pills have many advantages as compared to disadvantages, and the advantages outweigh the risks associated with oral contraceptive pills. So, what are the beneficial effects of combined oral contraceptive pills? They prevent abnormal uterine bleeding. Women who are on pills, they bleed regularly, and the blood loss during menses is also decreased. So, they are very, very good for women who have heavy bleeding and they are on pills. Their bleeding gets regularized, their bleeding gets minimized. So, abnormal uterine bleeding gets there's a relief of abnormal uterine bleeding when the woman is on these pills. Oral contraceptive pills, they also provide benefit against dysmenorrhea. So women who are on the pills, they absolutely have painless periods. So ovulatory cycles are painful actually, because it is during the time of ovulation, that these prostaglandins are released. It is during the time of progesterone withdrawal that another set of prostaglandins are released, which cause dysmenorrhea during periods. So painful periods, they are relieved when a woman is on oral contraceptive pills. Mitchell-Schmerz, this is what is we call as the mid-cycle pain, which is associated with ovulation. So women who are on the pills, they're also relieved of this mid-cycle pain. Endometriosis, PCOS, acne, and hirsutism, they all improve with the current oral contraceptive pills. They can be used as a method of hormone replacement therapy also. They decrease the risk of ectopic pregnancy, decrease the risk of PID. So these oral contraceptive pills, they cause that cervical mucus thickening, and they prevent the ascent of infective organisms, and ascending infection is prevented. That's how they decrease the risk of PID as well. They provide protection, decrease risk against benign breast diseases like fibroadenosis and fibrocystic disease of the breast, provide protection against the development of functional ovarian cysts. So mind you, oral contraceptive pills are not used to treat functional ovarian cysts, but they provide protection against development of functional ovarian cysts. Now I have a question here from Dipesh. Is there a risk of breast cancer? Now the risk of breast cancer is riddled with controversies. There are studies showing that there is no consistent risk. There is no increased risk. There are studies also showing that there is an increased risk of breast cancer with oral contraceptive use. What is good to see, what is good to believe is are on the side of caution, right? So with oral contraceptive pills, what is definitely certain is that the risk of breast cancer is only seen with current usage of oral contraceptive pills. So women who are on current usage of oral contraceptive pills, they are at slightly increased risk of breast cancer. Slightly increased risk of breast cancer is there, but the risk is only limited to current usage. So if a woman stops taking the pill, because nobody takes these pills for a very long duration of time, supposing the woman has taken for 3 to 5 years, she's anyways in that age group, she's in the 20s or 30s, where age-related risk of breast cancer is also not significant, right? So only current usage of OC pills increases the risk slightly for breast cancer. Once the woman stops taking the pills, on stopping the pills, the risk normalizes. The risk normalizes yet again. So that is the latest evidence. Berulal, can it be used to treat metrorrhagia? Yes. Metrorrhagia is an older term for irregular cycles. Yes. So any abnormal uterine bleeding of any kind will be benefited by using oral contraceptive pills, even irregular cycles like metrorrhagia. Now let's have a look at the next question. Okay, I have a question here. Which type of contraceptive pills is best to use? Now, which type of contraceptive pills are best to use? The ones that are coming in the market, they are the ones which are containing 30 micrograms of ethinyl estradiol plus your levonorgestrel containing ones, which are 150 micrograms, right? So they are very safe, very efficacious. Even low dose ones, which are 20 micrograms ethinyl estradiol, plus desogestrel containing ones, they are equally efficacious. So as far as the action, side effect profile, as far as the beneficial effects are concerned, they are same across the different types of combined oral hormonal contraceptives. But yes, one thing that I would like to add here, that women with acne and hirsutism, this group of women or women with PCOS here, which have high levels of androgens in their body, they particularly benefit from the anti-androgenic action containing progesterone. So you can use those ones like the drosperinone containing ones. The drosperinone containing pills are preferred. The limitation is that drosperinone containing pills are available in the market, but they are expensive to use. So yes, we can use the ones which have anti-androgenic. So this is a progesterone which also has anti-androgenic action. So women with acne and hirsutism, if they are on pills, they should be prescribed ethinyl estradiol plus drosperinone containing pills. But yes, even then, they can also be prescribed these pills as well. There's no limitation on prescribing the other hormone pills as well. Now, let's move again to the next question. So there's a 24-year-old woman who requests combined OC pills for contraception. She is healthy but has occasional migraines. Her cycles are irregular. Their cycles are regular. She has a strong family history of diabetes and her grandmother has recently been treated for breast cancer. You advise that using OCPs for her can increase the risk of breast cancer, migraines, diabetes mellitus, or stroke. So mind you, this is a 24-year-old woman who's otherwise healthy. She just has occasional migraines. Her cycles have been regular. She does not herself has a history of diabetes. She does not herself have a history of breast cancer, but there's a family history of diabetes and there's a history of breast cancer in the grandmother. So you advise her that using OCPs for her can increase the risk of Saeed Abdu and Mariam and Nana also the opinion that migraines. Yes, so the risk of migraines was increased in this particular patient. She has a family history of diabetes, not a personal history of diabetes. She has a family history of breast cancer, not a personal history of breast cancer. So for her, the risk of having diabetes or breast cancer is as equal to any other woman, even if she uses oral contraceptive pills, but she herself has migraines, right? So the chances of increasing migraines, the risk of migraines episodes being more frequent also increases when a woman is on oral contraceptive pills, and particularly so for women who themselves have a history of migraines, right? So please keep that in mind. And another Deepesh rightly saying that her grandmother had a history for breast cancer. So in that particular scenario, her grandmother must have had a sporadic breast cancer. I mean, not going to say that she's inheriting any of the genetic mutation for breast cancer. So in this particular clinical profile, when she herself has a history of migraine, that is the reason for not prescribing OCPs, right? Not family history of diabetes or grandmother having breast cancer. Okay. Now, somebody was asking me, yes, Shataj, migraine only or migraine with aura? So women who already have migraine, without aura, migraine without aura is not an absolute contraindication of oral contraceptive pills, but yes, the frequency of migraines can increase in women who already have migraine, right? And if they already have migraine with aura, then I should not be initiating oral contraceptive pills at all. Migraine with aura is an absolute contraindication. Even migraine woman, even in this woman who has occasional migraines, I can give her other methods. No, that's the beauty of contraception. Oral contraceptive pills she's requesting for, then yes, I'm telling her that OC pills can increase her risk of migraines. Then she can choose another method. She can very well choose another method, isn't it? So I can use other methods where estrogen is not there. I can use progesterone containing methods only for her, not the estrogen containing methods. isn't it? Right. Now, Neo, you were asking me, how to take pills if oral contraceptive pills are missed. So, if just one pill is missed, then the woman can take the pill as soon as she remembers, right? For example, I was supposed to take pill the last night, and today in the morning I remembered, oh, I have not taken the pill yesterday. So I take it in the morning as soon as I remember, and then I take the next one as scheduled. Let's say, for example, I was supposed to take a pill last night, and today morning I didn't remember anything. I didn't recall that I'd missed the pill. And when I started taking the pill at night, I just realized that, oh, last night I'd not taken a pill. So this time I take two. I take the one that is due, and I take the one that was missed. So when a one pill is missed, one can take one as soon as she remembers, even if it means taking two pills at the same time. But when two pills consecutively are missed, when two pills back to back are missed, then I take one as soon as I remember that I have missed the pill, and then it would be more wise to use some backup method for the next 7 days, and expect that failure might happen when two pills are missed consecutively. Okay. Now let's have a look at the next question. There is a 36-year-old woman who comes to the gynae OPD for her routine checkup. She is using oral contraceptive pills for contraception. She has multiple sexual partners. She has a strong family history of diabetes and heart disease. She herself doesn't smoke. Her BP is 110/70. Her cardiovascular and pelvic examination is normal. Based on her history, you would like to perform which of the following tests? A pelvic ultrasound, an ECG, an oral glucose tolerance test, or a screening colposcopy. So she's a 36-year-old woman who's come for a routine checkup. She's taking oral contraceptive pills, which is multiple sexual partners. She has a strong family history of diabetes and heart disease, both. She herself doesn't smoke, BP is fine. You auscultate the chest, the heart, and the lungs are okay. Her pelvic examination is normal. So based on her history, you would like to perform a 36-year-old strong family history of diabetes. You would like to perform, I would say, an oral glucose tolerance test. There's nothing called a screening colposcopy. There is nothing called a screening colposcopy, guys. Colposcopy is not a screening procedure at all. Colposcopy is not a screening procedure at all. If I'm thinking that multiple sexual partners predisposes her to the risk of sexually transmitted infections, predisposes her to the risk of HPV infection, so I want to encourage screening for her. I want to encourage high-risk HPV DNA testing. I want to encourage pap smear screening, but I don't want to jump to screening colposcopy. Otherwise, I'll have to screen so many women with colposcopies. There are so many women, that will just increase this. There's nothing as such as screening colposcopy. Colposcopy is a second step test. When the screening comes positive, then we go for colposcopy, for colposcopic directed biopsy. So screening colposcopy has no clinical value at all. So even if I'm suspecting that multiple sexual partners puts her at the risk of HIV, puts her at the risk of sexually transmitted infections, puts her at the risk of HPV infections, cervical intraepithelial neoplasia, I want to put in screening in place, and screening by pap smear and high-risk HPV DNA testing, not by screening colposcopy, right? ECG, I am relying on my cardiovascular examination, am I not? If there's a clinical finding suggestive of an abnormality, right? If the heart sounds are abnormal, if I hear a murmur, then I would like to evaluate and investigate. Right? Pelvic examination is otherwise normal, so there's no need to do a pelvic USG. The cardiovascular examination is normal. There is unnecessary ECG required. But yes, with a strong family history of diabetes and she being 36 years old, it would be a nice time to go for an oral glucose tolerance test and screen for diabetes in this woman, right? Now, the pace, in spite of colposcopy, if pap smear an option changes, I have not placed pap smear in the option, but I would say if there is a pap smear in the option, then the fact that she is on oral contraceptive pills, I would still like to go for oral glucose tolerance test. Oral glucose tolerance test. Okay. I mean, pap smear being in the option would make it more would make it very difficult to choose. If pap smear would have been in the option, that would also have been a correct response. Okay, that would also have been a correct response. Then OGTT, I would like to do both. I would like to do both for this woman, OGTT as well as pap smear. So it's very difficult for me to choose one between the two. Okay. So these are the questions that I had for you guys today for oral contraceptive usage. Any other questions on oral contraceptive? Any other questions on oral contraceptives? I have this blank screen in front of me. I can take up your doubts. Any other questions that you want to ask about oral contraceptive usage? You can ask me. Tomorrow is another day. I'm going to take up another questions and then an MCQ series on contraceptives. So tomorrow I'll be taking up MCQs on the injectable, on copper T, Mirena. So I will formulate more questions like these, more clinical based questions like these on the other methods of contraception. If there's no other doubt, guys, I would like to bid you goodbye. And just to inform you about the free live classes tonight at 8 p.m. MCQs on partogram and clinical management of labor on the Unacademy platform. Two sets of MCQs I will discuss, one on 20th October, one on 22nd October. The timing is the same, that is 8 p.m. You can also check out the plus courses that are there on the Unacademy platform. There's a capsule course on reproductive gynecology, on high risk pregnancy, as well as gynae oncology. So I guess there are no further questions regarding oral contraceptive usage. I mean, if you go ahead and revise for today, you can always come back with your questions tomorrow. Again, tomorrow, same time, guys, on YouTube with more questions pertaining to contraception. Same time, 4 p.m. So I'll see you there. Bye. Bye, guys. Have a great day ahead. Subscribe to the platform. You can use my code SHONALI to get a 10% discount on your subscription package as well. So thank you so much. Thank you for your blessings, Izaz. Blessings to you too. Blessings to everybody who's seeing this video and watching this session. So bye-bye, guys. Take care. And thank you. Yes, Izaz, the option to download is always there on YouTube. There are a whole lot of sessions that I've taken over the past 4 months on YouTube. You feel free to watch them and leave your comments and get back to me on your doubts as well. I would appreciate that very much. Thank you so much. Bye-bye, guys. Take care.